Welcome back to day two of the third annual Academic Detailing Virtual Summit. This year we are focusing on community. We're also focusing on all kinds of novel, unique, wild, special, and very successful new applications of academic detailing in a variety of settings and across various scopes. Hopefully you were able to connect with other detailers or program staff during the first part of day two, as we spent some good time in breakout workshops for the past little bit. But now we're back in the main room, and it's time for our special plenary on the evolution of academic detailing, embracing new applications. And we have a trio of incredible women in the field of AD who are about to share their stuff. So without further ado, I will pass the mic to Mike, and he will introduce this section of presentations, and we will kick off. So Mike, over to you for the afternoon.
Excellent. Welcome everybody. Hope everybody had a great time in the breakouts. And now we're going to spend a little while hearing about, as Bevan said, three types of new and novel approaches. And I think what's so important about this is we've talked a lot about the context that we're all living in now, but whatever else is happening, as a field, we need to keep growing. We need to keep challenging ourselves, thinking about new ideas. That's true when we're in an environment where there's lots of support and funding for what we're doing, that we need to avoid getting stagnant and continue to innovate and to challenge ourselves. And it's perhaps even more true in a challenging environment where the people are concerned about funding and concerned about overall what kind of, is there a sympathetic audience out there for the importance of what we do? We need to keep innovating and thinking about how do we make the case for what we all know is so important, but we need to help the broader community in healthcare and outside of healthcare, policymaking, economic, and others understand. And that's why I think these, when I get to take a sneak peek at the slides. When I was looking at the slides and other things, was so excited to hear these three presentations and to get a sense of what are some of the innovative things that people are doing to take our field from the original models, from existing programs, and look for new directions. So with that as sort of an overview, let's go through them one at a time. Let's start with our first presentation here, which is from our really valued longtime colleagues in New York, here representing the New York City Department of Health and Mental Hygiene. Today is Michelle Dresser. She's the Senior Manager of Programming Strategy for public health detailing within chronic disease prevention at their department. In that role, she oversees much of their work in academic detailing. It includes campaign development, training, economic incentive work, provider selection, figuring out the targets, a focus on health equity. It's really covering the broad range of what it takes to be as successful as they have been. She also thinks about their strategic relationships internally and externally. So important for all of us who are thinking about how do you sustain a program. She comes to this with over 25 years of experience in public health, applies her experience to healthcare marketing. How do we deliver complex messages to clinician and consumer audiences? She's trained probably hundreds of representatives by now on communication skills, on the core elements of academic detailing to really make an impact. And she's going to tell us today about the innovation that she and her colleagues have been doing about how do we get at the challenges around maternal health and chronic disease. Michelle, excited to hear from you.
Great. Thank you so much for that introduction, Mike. It's always an honor to be asked by our esteemed colleagues at NARCAD to come and present to you all on the work of the New York City Department of Health and Mental Hygiene's public health detailing program. And so when myself, Bevan, and Anna started discussing this year's focus, it's funny, at first I was like, our maternal health and chronic disease model, I'm like, how innovative was it? But then when we were all started thinking about it, really, sort of challenging both primary care providers and OBGYNs to sort of take themselves out of their normal day-to-day comfort in the care that they give, really made me realize, yeah, this was unique in us. It was challenging. I'm excited to present to you sort of the highs and maybe a little bit of the lows, because not every campaign is an overwhelming success. This was a challenging topic for us, not only through development but execution. But we really think that we made some groundwork at the end. So, without further ado, yeah, let's jump right into the agenda. So, I think most people know on this call what public health detailing is, but just going to briefly go over that and how it sort of um, is a little bit different from academic detailing. And then an overview of the campaign itself, like what the rationale was for developing this campaign for the agency, how that was part of our strategic priorities as an agency, who our target audience was, what our key recommendations are of the campaign. And Bevan, just a shout out, I love that we should do onesies for Anna, key recs every day. Maybe we'll, get some sparks from here. Some of our popular materials. Very briefly, going to talk about the change in practice and really spend some time on what our provider and community feedback was and what our lessons learned were from the campaign. Okay, so excuse me. So I think, as many people know, public health detailing is very similar to academic detailing. That's a provider outreach and education program, really provider engagement, and that is modeled after the pharmaceutical sales approach. I think what may be a little bit different is that we are promoting overall public health interventions and selling good health through brief one-on-one interactions with healthcare providers and staff. Something that we really pride ourselves in public health detailing, and really sort of, I always say, takes a left turn from the pharmaceutical sales approaches, that we do something called the total office call. So our our goal is to really speak to everyone within the practice, from the front desk staff person to the provider to the administrator to the biller, even sometimes the security guard. You never know who in that practice is playing what role. And we know that everyone plays a vital role in patients' care. And just thinking operationally, like, providers don't have the time to implement all of these key recommendations, all these materials. So who are really your champions in the practice? And that's why it's important for us to see as many people within the practice as possible. And last but not least, is really to develop relationships and sustain them and serve as a resource to practice staff. Some of our practices we have been in for the last 15 or 20 years. And so we're really valued as a trusted source of information. And so it's very important, even in new practices, long practices, to develop and sustain those relationships. Okay, so we're going to dive right into the campaign. Next slide. Okay. So I apologize, a few of my slides have a lot of information, but I just want you to be able to sort of get the whole picture. So why did we decide as a health department to do not only a maternal health campaign, but a maternal health and chronic disease campaign? Like, what is that relationship? And so New York City, like many other cities and states within our country, is in an ongoing battle to improve public maternal health, with a focus on communities of color. In particular, Black women, or women who are racialized as Black, are 9 times more likely to die from a pregnancy-related cause, and 3 times as more likely to experience severe maternal morbidity than women who are racialized as white. Women of Latino origin also experienced SMM and pregnancy-related deaths at nearly twice the rate of white, non-Latina women. And structural racism has led to people of color having fewer opportunities to achieve optimal health. Because of structural injustices, women racialized as Black are more likely to live in environments that increase their risk of chronic diseases such as hypertension and diabetes. So it's starting to, formulate that picture of why these two should be in tandem in terms of a campaign. And then women with chronic diseases such as diabetes, heart disease, and hypertension are almost 3 times as likely to experience SMM compared to women without. And these inequities are just unacceptable and require healthcare providers from various disciplines to work together with patients throughout the life course. The life course meaning before pregnancy, during pregnancy, and after pregnancy to improve maternal health outcomes. Okay, very quickly. This campaign did uh, not just recently happen. It was something that was conceived actually before COVID. As many of you, I'm sure, were in the same predicament as us. A lot of work sort of ceased during COVID, and there was a shift in priorities. For us at the agency, this was one of them, although we were still working on the development of this campaign. And so it didn't launch until October of 2023, and it ran for almost 40 weeks through June of 2024. I'm not going to get too much into this because it's very relevant for New York City, but our team, due to capacity and sort of where the largest health inequities are in New York City, have a normal catchment area, if you will, in 3 areas of New York City. However, because of these stark racial inequities, we expanded the campaign to other areas, other neighborhoods of Brooklyn and in the Bronx in particular. And as we're going to talk more about, we expanded the target audience profile, which is normally for us internal medicine providers and family practitioners to include OBGYNs. During the course of the campaign, we spoke with or detailed 780 providers, 712 staff members at nearly 400 sites in these selected neighborhoods. Next slide. Okay. So I think this really sort of gets into the novelty and the rationale for a multidisciplinary approach amongst our audience. And so when we were developing the campaign and doing our literature review, it wasn't just we knew that what OBGYNs did on a day-to-day basis, what um, family practitioners and primary care providers did, but in looking at the data and the literature, OBGYNs often serve as primary care providers for people of childbearing age. They do not have a separate internist, so they are only seeking care from an OBGYN. But in seeing that OBGYN, they were less likely to offer preventative services for conditions not directly related to their specialty. So we saw this as a missed opportunity for care, which highlights the need to provide guidance on preventative services in the OBGYN spectrum. Additionally, the well visit in OBGYN is underutilized to not only discuss, but to diagnose and to refer for chronic health issues. In New York City, 24% of pregnancies are unintended, and those with an unintended pregnancy were over 1.5 times likely to experience an event of SMM. Additionally, women are very comfortable receiving a variety of primary care services from their OBGYN. So in some cases, even more comfortable talking to them than an internist. And it's estimated that 60% of pregnancy-related deaths were preventable. The most common contributors being lack of warning sign knowledge, provider misdiagnosis and ineffective treatments, and lack of coordination among providers. So this is really a well-designed educational intervention can help identify symptoms of SMM and MMM. And so this really spoke to us, especially when talking about warning signs, like where does the primary care provider play in the role of maternal health as well? So more to come on that.
And Michelle, just a quick reflection and also give you a chance to clear your throat.
Thank you.
Yeah, it keeps happening to me today too. I don't know what it is. There's a lot of really important pieces here, and one that I called out in the chat and just want to draw attention back to is comfort level of a patient, especially someone with an intersectional identity, someone who's racialized as Black and is a woman, and, all of the health outcomes on the prior slide, and poor health outcomes. This is it is a revolutionary campaign. And when you said at the beginning of your presentation, I wasn't sure, was this actually novel or unique? Like that alone, considering, hey, would a woman of color, would any woman feel more comfortable with their OBGYN than their PCP? That is radical when you think about, sort of approaching it from this dual, provider AD approach. So just wanted to reflect on that. Yeah, back to you.
Yeah, that's a great point. Thank you. And you gave me a chance to take a sip of water. Okay, we can go to the next slide. Okay, so in looking at that literature and working with our work group, which is comprised of internal DOH experts within the field of chronic disease and maternal health, also people who have lived experiences themselves, as well as members of the public health detailing program, we came up with 5 key recommendations, which, as you all know, are the cornerstones of your academic detailing or public health detailing work. It's really your goals that you want your practices to implement. And so when thinking about a dual audience or a dual approach, like what are the recommendations that can be implemented, albeit hard in some cases, for both primary care and OBGYN. And so the 5 are: screen all patients for hypertension and those at risk for type 2 diabetes during well visits to make sure there are no missed opportunities for care, and refer patients who meet diagnostic criteria to appropriate follow-up care. 2, to engage all patients on healthy eating, being physically active, and maintaining regular follow-up to optimize their maternal health. 3, provide patients with self-management tools and resources to support them in managing their hypertension and diabetes in between office visits and throughout the life course. Remember, the life course being before, during, and after pregnancy. Speak with patients who are pregnant about the New York City standards of respectful care at birth, which is something not necessarily unique to New York City, but these are New York City specific sort of laws or rules that you must have, a respectful birth. And so if not, that you can make a formal complaint or make a legal complaint to support the highest quality of healthcare during pregnancy, labor, childbirth, and afterbirth. And finally, to support patients in recognizing and getting care for the warning signs associated with severe maternal morbidity and maternal mortality during pregnancy and after birth. Actively listen to patients and encourage them to share concerns about their physical and mental health. So you're probably thinking like, I bet primary care is doing some of this, and I bet OBGYN is doing some of this, but how do they each think of those things? So we're going to talk a little bit more about that. Next slide. Okay, so as in all of our campaigns, sort of the cornerstone of our work, I know it is of all of your work, is applying an equity lens to everything. And so for us, it really looks at 3 different components. It's within our development. As I mentioned before, our work group consisted of health department staff with diverse backgrounds and lived experiences. Campaign materials name racial inequities explicitly and structural racism as a cause of SMM and MM inequities. Additionally, we are fortunate enough to work with health literacy consultants who do focus groups for us so that we can work with members who live in the communities that we target to give us feedback on whether our messaging for the public resonates and whether they would feel comfortable taking action in working with their provider on these. In execution, it's where we're targeting our intervention, and in evaluation, by interpreting findings and collecting data using an equity data framework. And the way that we do that is we apply principles described in the We All Count data equity framework, and then we triangulated quantitative and qualitative data to better understand the nuances of care delivery. Okay, So going to talk about our popular materials. So with every campaign to support the implementation of the key recommendations, we develop an action kit, which consists of clinical tools, provider resources, and patient education materials. And so this was a pretty large kit. And I want to say we had something like 18 or 20 pieces that we developed through this because of those complex key recommendations. So we want to make sure that each um, thank you for linking it in the chat. So we wanted to make sure that each one of those key recommendations were supported, and that meant developing multiple pieces. On the provider side, two pieces that really stuck out was improving communication between the provider and patient, really like, you know, having the provider better understand that bidirectional communication, giving the patient a chance to really express potential concerns around maternal health, really. Looking at their own potential internal biases around maternal health. And so that was very popular. Additionally, I'm going to move quickly. Additionally, we developed a resource guide. One of the things that we're asked with a lot is what are community resources to better partner with on these interventions? And so we did develop a New York City resource guide on this. And then on the clinical and the patient side, we have had for years in the health department something called the My Adult plate planner, and we adapted that to have a pregnancy plate planner. I talked about the warning signs before. We had a warning signs card and a poster to really empower patients to look for those warning signs, not only before pregnancy, but after birth, because warning signs can happen for a fairly long time afterwards. Usually they're pretty acute within 6 days after birth, but can happen for weeks and even a couple of months after giving birth. So that's just to highlight some of the materials. If you're interested, the full kit is linked in the chat. Okay, so very quickly, and if anybody is interested in hearing about the full spectrum of clinical practice change, I'd be happy to talk to anybody offline. But we observe when looking at our key recommendations, we observed statistically significant changes in 4 out of our 5 key recommendations. You will see it's slight, but it's there. And as I mentioned at the top of the campaign, it was challenging to get primary care providers maybe to really embrace things like talking about warning signs. And on the flip side, really getting OBGYNs to really embrace not only talking about chronic disease with their patients, but implementing such as diagnoses and management treatment. I think a lot were more willing to do a warm referral, which was great because, as we mentioned at the top, a lot of women did not have a primary care provider. So we were happy about that. We can go on to the next slide. I think, I didn't want to spend too much time on that because I think these last slides are really sort of give more of that qualitative feedback on the campaign. And so, as with every campaign, our reps, they are master communicators, but they're going to run into some barriers. And in every campaign, they really use persuasive communication techniques. They use data to highlight the problem, to really frame the issue, and to highlight relevant materials and connect providers and practices to other programs or interventions that would be helpful to them here at the Department of Health. Specifically for this campaign, as I've been mentioning, siloed care was definitely a barrier. Primary care was saying, that's not what I do. OBGYN was saying, that's not what I do. And so we used not only statistics, but with statistics really pointing out the stark inequities, that this is epidemic, this is and to really use clinical recommendations within our treatment and management guide to help them see where their intervention as either a primary care provider or an OBGYN was not only relevant, but was vital to improve maternal health outcomes in New York City. Again, just really educating providers and staff on the inequities and even sharing high profile stories, not only that have occurred in New York City, but have occurred around the world in the last few years. And then a barrier that is not unique to this campaign is around social determinants of health, especially around healthy food and medical services. And so we were able to share our resource guide. Next slide. Okay. So next is a couple of slides about community and provider feedback. So this is just one of the things that our representatives do is in collecting that qualitative information is really telling, is in that storytelling, bringing back the actual stories of the providers and the staff. And just to point out a really positive one and then maybe a not so positive one, maybe a more skeptical one is on the right-hand side. And so the provider shared she is now never without the kit near her. She uses many pieces in the kit to counsel a patient who wanted to get pregnant and suffered from depression. And on the flip side, another provider who said she liked and appreciated the kit, but said if we don't fix the social determinants of health, nothing is going to change. So
Yeah.
just more work to be done. So the next three slides really talk about the feedback. The first one is on the overall reception of the campaign. And so as I had mentioned, many primary care providers viewed pregnancy-related care as out of my scope, and many OBGYNs viewed primary care as out of my scope. Additionally, the political landscape, including changes to abortion availability after the Dobbs decision, colored reception to the campaign, but heightened interest. Got a lot of personal stories shared about that, about access to care and maternal health issues um, uh, in their own journeys. And then most providers believed in the power of patient self-advocacy and wanted their patients to be empowered in their decision making. And one of the tools that was developed for the campaign was just that, a patient empowerment tool, really giving them the coaching scripts and the strategies to stand up for themselves and to speak for themselves and say, something's not right, I need your help. And again, continuing the feedback around equity and social determinants, providers independently raise the topic of social determinants of health. We've talked about this around food, around care, and overall health inequities. Providers did begin to discuss structural racism and its impact on health outcomes on their own. And while this topic has come up in previous campaigns, it was discussed more directly by providers here. They really saw uh, the importance of it. Not that they didn't before, but really in showing these stark inequities, really it was an aha moment, if you will. And then, notably, some providers had negative reactions to the campaign, explicitly naming structural racism as the cause of maternal health inequities. PhD reps, as I mentioned, very good communicators. They were able to descale these conversations as needed and sort of reiterated the messaging, the data, the framework, and the material around this health crisis.
Can you provide just a quick touch of context about what the negative reactions were sort of, what was the context there?
I think, if I remember correctly, some providers are like, you just don't live in my space. You don't see what I'm seeing every day. I have to see X number of patients. You're asking me to do something that's out of my norm. That's not actually the root cause of this problem kind of deal. So it was coupled, I think, with their own frustration in healthcare in general, and sort of taking it out on this in particular. So I don't think
Gotcha.
it was unique necessarily to the campaign,
Gotcha.
but maybe in healthcare in general. And then finally, around healthcare access and work for workforce, providers express concerns around healthcare access, finding care, prenatal care, and OBGYNs accepting new patients. So we help to navigate some of that by utilizing our resources and context. But the team encountered more content champions during their detailing visit, which is great. On one side, it's because people who live in the area have lived experiences, work in these clinics, and so it really sort of hit home, if you will. And it like speaks to the community's investment in the campaign and belief that this needs urgent attention. Um, and as I said, it resonated in a visceral way with many of the non-provider staff just because of their own lived experiences. Okay, I am closing up. So this is sort of considerations for future outreach, a little bit geared towards us here at the health department, but I kept it in because I think it is relevant across many people's work when you're thinking about maternal health as a potential topic. So that more work is needed to convey the idea that primary care and maternal health care fall along a spectrum which cannot be assigned exclusively to one type of provider. For us here in New York, we have many new arrivals, and they have been having difficulty obtaining prenatal health care. So, working with our maternal and infant reproductive health care colleagues in letting them know about this. And so we have a program called the Newborn Assistance Program, Nurse Family Partnership, and really helping to overcome that barrier. And then providers continue to raise concerns around patients who do not seek prenatal care or who seek it late in pregnancy, sort of like saying, well, the onus is on them. Like, I can't help them. And that's why it was so important in the primary care spectrum as well to start having these conversations around family planning in relation to chronic disease management. Because if we diagnose and treat and manage chronic diseases well before pregnancy, we can have better maternal health outcomes. And so another thing is partnering with pediatricians. We did not target pediatricians for this campaign, um, but it's a really good idea in terms of like warning signs, like at that 6-week visit to really, that well check to really ask the parents and the mom, like, how are you doing? Do you feel okay? So there was another opportunity for intervention there. Thank you. I'm sorry I went over a little bit, but
It's
just
okay.
I just wanna say a quick special thank you to my team because I have the honor of presenting, but all of them we could not do this without each other. So Nina Shabbat, who was our evaluator, who did all of the data analysis and data collection, our representatives who actually do the detailing, and my co-lead in the department, Lisa Petrosoric, who oversees all of our day-to-day operations. So thank you for the opportunity.
Thank you so much, Michelle. It's an incredible campaign, and I want to turn it over to folks with questions. So any questions for Michelle, you can pop them in the chat, or you can unmute and just start talking. I know I have some, and I don't want to hog up the space, and I know Mike has some too, but please do share your thoughts and reflections. And we'll give folks a minute to chat in the chat box. Popping that maternal health action kit back into the chat. So many incredible materials there that folks can take a look at. All right, Mike, it's over to you. Oh, no, we got something from Jackie Travers.
Do Jackie.
Made you look. Were the maternal providers surprised to find out care and screening was absent from primary care?
Meaning were the OBGYNs surprised that PCPs were not doing maternal health screenings?
I think that's right. Jackie, do you want to unmute?
No, I don't think so. They were both kind of like, this is what I do, this is what they do. But I mean, there was a lot of ground softening. I will say, primary care providers were much more open by the end of the campaign to having that conversation. During that to start having family planning discussions. And then on the other end of the spectrum, after if they would see patients like very soon thereafter they had birthed a child, to ask them about warning signs. So there was definitely movement on the maternal side with primary care provider. And on the flip side, I think OBGYNs basically were willing to diagnose hypertension and diabetes unrelated to gestational hypertension and diabetes, because that occurs in every pregnancy, but chronic, to do referrals into primary care. So that wasn't happening before. So those in and of itself were big wins for us. But I don't think anybody was surprised at who wasn't doing what beforehand.
Right. Well, thank you, Michelle. We do have to move on, but if anyone comes up with questions, other reactions, please pop them in the chat. I will triage those over to Michelle and her team. Thank you so much. And back to Mike. First, we have a quick chat waterfall. Throw on into the chat some thoughts, audience members. When you think of the word patient detailing, when you think about changing patient behavior, what do you think would be the biggest barriers if you tried to apply the AD model to behavior change with a patient? All right, Erin is kicking us off with kind of one of the words thematically of the conference: misinformation. Yes, overcoming habit. Thank you, Nick from West Virginia. Health literacy. Yahaira says misinformation and where they obtain their facts. Trust, for them to actually trust the info being given to them. Mike says patients feeling overwhelmed by the volume of information. Narissa brings up a really important fact from Chicago: health literacy levels. Jackie says resource access, relevance to their daily lives. And Christine really wraps it up, sums it up well. Change is hard, right? Change is hard. We dig in our heels. So without further ado, Mike will introduce our next presenter, who did not flap her wings to get here this year, but she is up extremely late over in Australia. So Mike, to you, and then to Deb.
Yes, delighted to welcome Professor Deborah Rowett, where it's either very late or very early, depending on how you think about your days. But Deb has been one of the major figures in international academic detailing for years. She's a classic triple threat of a clinician, educator, and researcher. She's the director of DATIS, which is the Drug and Therapeutics Information Service in South Adelaide, in Australia. She's really done some of everything in our field, working on quality of use medications, interprofessional practice, health policy, workforce development. Has worked with people from a wide range of countries, many continents, on thinking about the underlying principles of academic detailing and on specific program development and evaluation. But she's also always stood out as an innovator, thinking about what's the next thing coming down the road and the next new idea. And that's why we're so excited to hear from her today about her the work she's been pursuing for a little while now to build out this idea of patient detailing. So Deb, we're very excited to hear from you. You can bring us tomorrow's news today for all of us.
It's true. Right. How's the future?
Thank you very much, Mike. And I'm very pleased to be here and part of the summit. And it's a great pleasure to, work with you over many years, Mike and Bevan and your colleagues, because we're always learning. We're always learning about, with, and from each other, and that's what I suppose drives me each and every day. So I want to just share with you around patient detailing as a novel approach, and perhaps just move on to the next slide, because, compared to the original model of academic detailing, and everyone involved in this summit and online today will be very familiar with the principles of academic detailing. And it was interesting to see the comments in the chat about what might be the barriers to patient detailing. And when we look at those principles of academic detailing, that assessment of the motivation for current practice and personal barriers to change, but also those, when we think about credibility of the visitor, how we encourage participation in a visit, how we use concise educational materials. And, the workshop that Bevan and Jackie ran that I was involved, I participated in around hearing the consumer voice. We are already seeking out the consumer voice. We are already having resources that we include in our detailing for providers that we are through them wanting to use, wanting to support them in their discussions with patients. So if we look at those principles of academic detailing and move on to the next one, thanks, Bevan. When we think about the implementation of how we're doing that, it's either face-to-face or online. We're using a structured framework. We are really critically delivering to meet the needs, attitudes, and beliefs of that person visited. And most of those are either clinicians or health professionals. They might be care workers, but they are, even within those groups, that health literacy, the habits, the evidence, some of those things that came through in that chat waterfall also apply to the providers and our current way in which we think about academic detailing. And understanding the motivations for practice is really a key part of academic detailing. Next slide, thanks. And so, some of this work, we continue to explore and try and understand our field of academic detailing, and really understanding what are the key features of academic detailing. Mike knows that I'm very interested in trying to understand why does academic detailing work? When does it work? How does it work? Really trying to explore that so that we can continue in our field to make it more scalable and sustainable. Because I would suggest, and I'm sure that all of you who are online, it's never been more important to have academic detailing, that way in which we take population level evidence and make it accessible for clinicians to use with their individual patients. And so just in this statement from this work that Mike and his colleagues did was, it's around detailers need those skills to identify providers' baseline knowledge and motivation for prescribing patterns. But I'm like to put to you today about patient detailing. How do we develop those skills, and how do we use the skills that we have honed to do that with providers, to do that with patient detailing? Next slide, thanks. Because we are already trying to move, the interaction beyond just communicating information. We really, really focused on understanding where people are currently at. That's the skill of the academic detailer, is to be able to elicit those needs in a short space of time. So it's not an interrogation of the person, but the skill that we have acquired to be able to have those conversations. And we want to encourage voluntary action. And I think in the chat waterfall, it was about changing habits. And we know how hard that is to change habits. But we are not just influencing knowledge, but we are behaviours and attitudes in our provider academic detailing work. Thanks. Because, it really does bring the best available evidence to where care is delivered. And we do tailor it to the knowledge, experience, responsibility of that person that we're visiting. We use the, and NARCAD, you've got a lot of those resources around program design, visual representation of data and evidence. And, it is underpinned by a service philosophy. Next slide, thanks. Again, just be very familiar with that structure of an academic detail, that context, the exchange, how we gain commitment. I'm not going to go through that in detail because I'm sure many of the educators and those involved will be very familiar with that framework for academic detailing. Thanks very much. So could we use that framework? Could we use those principles and apply them to patient detailing? Using that same rigor, evidence, and theory that we've know of academic detailing to influence patient behaviours using this technique of academic detailing, or the principles at least of academic detailing. It is a novel concept and it has been tested in a limited number of studies. I've been involved in a few. We've done studies in the palliative care space, in chronic obstructive airways disease, atrial fibrillation, and now we're thinking about it in the context of rheumatology. Next slide, thanks. And also stroke. This is just one example that I'm just going to highlight, which was a randomized controlled trial of 627 patients who presented to our emergency department in 6 hospitals in Adelaide. Patients were randomized 1-to-1 to an intervention that used the principles of academic detailing, and patients were followed up over a 24-month period. Again, in thinking about the context of atrial fibrillation, it is one of the most rapidly growing concerns for our health system, the number of presentations to hospital, and the burden for both individual patients and our health services continues to grow. Next slide, thanks. So again, I'm not going to go through the RCT, but really how we think about it from a patient detailing perspective. And so again, in this, we use the same principles as I outlined at the start of what academic detailing is, to identify what are the evidence to practice gaps, where would we be wanting to focus a campaign of academic detailing for patients. And an important theme related to patient uncertainty concerning management of AF episodes. So it wasn't about medicines, anticoagulants, telling them all about their medicines, but how do they manage uncertainty when they present with an AF episode? Because in our randomized controlled trial, we actually chose, the inclusion criteria included younger patients. When I say younger, so not the really older patients with multiple comorbidities, sort of in their late 80s and 90s. These were the people presenting to ED with the symptoms of their AF. So that was the particular cohort that we were looking at in this. And so we used the same principles. We developed key messages a priori. I'm sure some of you are thinking there, well, how does patient detailing differ from perhaps motivational interviewing, for example? And I've had these conversations with others before. But I think in the technique of academic detailing, we really, the design, the rigor, but focusing on evidence-informed a priori key messages is something that sets it apart from some of those other approaches. There is certainly overlap, I would suggest. And our goal is to empower individuals to self-monitor and manage their AF. Thanks. And so you'll be very familiar with those who design academic detailing programs, the visual representation of the resources, the key messages there. But in this particular one, I just want to focus on key message 3, which was around reducing a risk of more severe and risk of stroke by choosing a healthy lifestyle. Now, most clinicians and providers, when we go in, I noticed in Michelle's presentation, she talked in her presentation about managing some of these lifestyle risk factors. Most providers look at you, it's a bit of it's a hard habit to change, isn't it, some of these things? So we really focused on this. And again, based on the principles of academic detailing, where you're trying to understand kind of baseline where people are at. So in this patient detailing, we undertook a baseline profile of each patient's cardiovascular risk, a factor profile, and it was undertaken prior to the home visit. And based on this, we were able to sort of have an understanding of their some of those areas perhaps of need, so we could personalize it and tailor it to them. Thanks, next slide. And again, just, similar to other academic detailing, booklet that was, illustrated in a way that was engaging, support the delivery of the key messages across detailers so that there's consistency of those key messages. Again, like many of your NARCAID resources around how to produce graphical aids that support that interaction. So they're not designed to be an information resource, they're designed to facilitate the conversation. Thanks. And then again, they're, as I said, not just for knowledge, they're also for behaviour change. And as I said, this program was identified how to manage your symptoms of AF when you have an AF episode. So we came up with a personal rest plan, not an action plan, but a rest plan. And then it's not just having the rest plan, it's giving them the questions for the doctor and working through that so that you are enabling their conversations that they're going to have with the provider. So really the resources we looked at the features, benefits, barriers, and then we designed our materials to address those. Next slide, thanks. And that included, for example, in that work, identifying that most people didn't know how to take their pulse. So we gave them resources on how to take their pulse, because it might be that when you're encouraging them, to identify their usual symptoms for AF and what they're like at baseline. So just, how to take their pulse was an important part of this program as well. Next slide, thanks. So similar to the structure of academic detailing that I put up at the start, what we had here for patient-centered academic detailing was, again, you'll see here the context. We chose the home environment, but also deliver online. But like in academic detailing, we wanted to be as close as real time to where they make their decisions, where care is delivered. That connection, in person or on phone conversations, so that we could be able to address that patient's interests, needs, and motivations, similar to academic detailing. Again, that conversation, unhurried conversations to explore and address patients' fears and misconceptions, really allowing that time to listen to them and individualise a limited number of key messages that have been determined a priori. And that commitment that we have in academic detailing to empower the patient to undertake self-care and agree on behavioural goals. Again, I'm sure you're seeing the similarities to our other forms of academic detailing. Next slide, thanks. So patient detailing, it is about building trust. I think one of the things I focus on a lot in that work is around psychological safety, where we're trying to create an environment that really creates a safe environment for the patient so that, we foster that environment so it's inclusive of their voice so that they feel that they can share their experiences, just as we do with providers in that trusted environment. I also, in patient detailing, think about sense making. And I like that concept of sense making because, there's a lot of information. And that actually came out in the chat waterfall. So I was really interested to see that there. Because for me, when we think about sense making, there's a lot of information. But what we're trying to do, I suppose, is in sense making, it's that concept of sufficiency, that they have enough information to make a decision, not adding to complexity or ambiguity, but helping them to make sense in their environment and for them to make decisions. And just moving on then, well, what are the opportunities? Models of care are changing. Cardiovascular, this is an integrated care model for AF management. There's a lot of people in that team. And in routine clinical practice, patient education is often opportunistic, it's time constrained. So most clinicians, haven't had training like you have had in educational theory and behaviour change methods. So having a few members of that team trained and skilled in patient detailing is an opportunity going forward in integrated multidisciplinary care teams to enhance the outcomes. Thanks, Bevan. So we can, I think, influence effective behaviour change. Just, team members of those integrated care clinics trained in the method of patient-centred academic detailing. And that's what we've been doing since the development of the Help Aid, since some of those trials and research we've done. You can see there implementing personalised education includes those key principles of academic detailing. Next slide, thanks. And again, in patient detailing, the same rigour of the educator or the academic detailer does need to understand the area that they're working in, have at the work environment, the workflows, co-designed with patients, similar training to academic detailing. and, you know, achieving that commitment to behavioural goals. In Australia, there's a bit of a changing landscape with a greater focus on primary care. Thanks, next slide. And in that primary care, the opportunities for patient-centred academic detailing, where in that primary care model, if we move from patient management with a focus on what is the matter with the patient to patient activation and person-centred care with a focus on what matters to the patient, there can be increased opportunities for patient-centred academic detailing. Thank you. And in other, in the UK and in Australia, there is a focus on social prescribing. You may be doing social prescribing in some of your primary care settings. And so I think with the increase in social prescribing, certainly in the United Kingdom, there's a whole lot of resources. I look at the competencies for people who are who are going to undertake social prescribing, and I see there's opportunities for patient-centered, or people with the skills of patient-centered academic detailing to really make a difference in this area of social prescribing. Thank you. So it's accelerating in Australia too, with a number of our primary care providers, where in here you're connecting individuals with non-medical support within their communities. And over the years that I've come to the NARCAD sessions, I know you do a lot of public health detailing in the US. Thanks. So person-centered academic detailing, I think they're not enantiomers, they're not directly superimposable of patient academic detailing and provider academic detailing, but I'd like to suggest that they are enantiomers and that they are similar principles underpinning them, and similar outcomes may be able to be achieved. And we need to obviously do more research, understand them. As I said, I am interested in the theory of that behaviour change for patient-centred academic detailing. It's still tailored to the person, their knowledge, their interest. And I think sense making, where you develop a shared understanding, enables more effective and aligned decision making. And finally, it involves understanding existing behaviours. It embraces complexity and uncertainty. And uncertainty seemed to be a theme of the start of this summit, and, you know, connects still face-to-face and in person and online, but close to where care is delivered for individual patients. So thank you very much for the opportunity, and I hope I've been on time.
Thank you, Deb. We appreciate you. And it is so important to think about how we can take the model and apply it in different ways. So open to questions. Please do let us know if you have any. I'll give it a moment for them to pop up.
Can I?
Yes, you can.
I have one that I'm going to take the introducer's privilege. Thank you for that. That was really interesting. I love your reflections on a tension that we've talked about a lot in sort of classic academic detailing to prescribers, and how you think about it with patients. We've, over the years, lots of times had conversations about academic detailing or public health detailing, and, you know, where people use the term counter detailing. We, you know, a lot of the early academic detailing studies were more sort of explicitly maybe counter detailing to a maybe an advertising campaign by a pharmaceutical company, or something that perhaps misrepresented or oversold the benefits and so on. And we would go back and forth. There was a push-pull about, you don't want to just be defined by countering what was said, but if you ignore sort of the problems out there, maybe you miss the mark, versus just having a positive evidence-based message. And for patient detailing, that seems especially important now, because there's a great deal that we could teach patients about and choose positive topics, but there is so much misinformation out there now. The information environment's gotten so difficult that we might say, geez, we should really focus on counter detailing. Let's identify some of the most dangerous messages and counter those. How do you think about that balance of choosing a positive message versus countering maybe some of the negative ones.
Yeah, and I think I mean it's a great example. For me, I would from what we've done, I probably wouldn't go down the counter detailing path in the first instance, but rather go with the positive messages, because you are close to because you're trying to get a change in their behavior, listening to them, what's important to them. If you go down the counter detailing path, you are what's important to you to change their behavior. If I can just thinking about it in this moment, and also because we in AD have our a priori key messages based on the best available evidence, and using a range of resources to just really narrow that down to 3 or 4 key messages, because that's the behavior change we're looking for. I would, in this case, still at this stage, in this early stage of patient detailing, focus on those positive evidence-informed messages. And that's why I see the real advantage, is because there is so much information. We're bringing, I think, decision and wisdom to this. So that would be my response, Mike, I think.
Thank you, Deb.
Yeah, incredibly helpful. And no surprise, such a thoughtful answer. Should I segue right into this intro, Bevan?
I just wanted to say, Deb, you also have a really thoughtful reflection from one of our colleagues in Canada in the chat that you can take a look at. And thank you so much for being here with us so early in the morning in Australia, and for giving us a new way to look at detailing and think about how we might try to apply it. I know at NARCAD, we've secretly, and now not so secretly, been poking around thinking about, could we do a patient detailing model? So segue away, Mike, and thank you, Deb. Appreciate you.
Thank you.
Yes, absolutely. Very excited for the third. We see everyone can see that nice University of Texas orange up there for our colleague Melanie Susswine. So Melanie oversees the Texas Child Mental Health Care Consortium project. This is a critical resource for addressing mental health challenges and increasing resources for Texas children and adolescents. She's been working in communications for over 2 decades. She's won awards for communication strategy. She's also a qualitative researcher and a leader and manager. She's done extensive work on women's health issues in Texas and nationwide. And so we're really interested in learning from her about the innovative work she and her team in Texas are doing to increase access to care. Melanie, over to you.
Thank you so much. I'm very excited to be able to share all of this. I have no issues, no disclosures. So what I want to do today is I want to tell you a little bit about our center and how we're situated in the university, give you an idea of the program that we're working on and how we've used academic detailing, some program highlights, and then we'll have some Q&A. I'm kicking myself because I do not think I have a slide in here that shows what I think the impact of what we've been doing, which is like our numbers have been increasing. So next time there's already room for improvement in that. So what we do here at the Center for Health Communication at UT Austin, the way that we work in the different colleges is we have centers or research institutes that help advance academic scholarship. And what I do is I work in a center, and we're in the Moody College of Communication, and our scholarship is health communication. So evidence-based, research-based health communication. That is what our discipline is. So we do research, we create insights, then we create strategy and messaging, and we create different tactics. We're almost like a little mini advertising firm that focuses on public health and health communication, but we're embedded inside the university, which affords us a lot of luxuries in terms of being able to do deep dives to get evidence-based information. So the project that I am working on, the Texas Child Mental Health Care Consortium, this is an access project. Many states in our country have access programs. I think over half of the states in the United States have this. And the purpose of these access programs is to increase access for mental health care. The way that we work is we're embedded in the 12 medical schools in Texas. Those medical schools have psychiatric departments that work as regional hubs. And so the regions can then access those areas to get quick information. So what we're trying to do with PeriPan and CPAN, and I'll go through what the different programs are, is to allow doctors to quickly access psychiatric expertise so that they can take care of the patient. They remain the primary person, the primary provider, and they consult with us, a curbside consult, to get what they need to be able to address the child or the perinatal woman's need in the office. We have many counties in Texas, as do many other states in the country that have rural and frontier counties, where we do not have child psychiatrists and we do not have reproductive psychiatrists. And people wait months. And in many cases, there's no reason to wait months anymore because we have these programs. So the CPAN is the Child Psychiatry Access Network, and we focus on pediatricians, family docs, physician assistants, nurse practitioners. And then PeriPan is the perinatal access program. So we also just add OBs to that area, even though it's quite different, the communication with them a little bit. And then TChat, we do something very similar in the schools, where in Texas, each district has the opportunity to have telehealth with a clinician through this program. I'm going to be spending my time talking today to you about CPAN and PeriPan, and that is where we have really employed academic detailing. The way that we started before I knew NARCAD existed, and I was so excited when we found NARCAD and we could add the evidence base to what we were doing, is that we divided the project equal parts outreach and then media, which kind of is the big umbrella for our social media, digital media, all these different things to drive information to the clinician. So what we're trying to do when we put it in traditional academic detailing terms is when you're trying to have a clinician adopt something, we want them to call us. That is the pinnacle of the behavior change that we want. We want them to use all of the different access that we provide them to reach out to us so that the child or the woman can be seen right there in the office. And we do really make it as easy as possible, totally understanding how busy clinicians are and how even 2 minutes can disrupt their day. And we continue to put different strategies in place, like you can write us and say, I would like a call back by a psychiatrist at 2 o'clock tomorrow, and we will do that so that they can get the help that they need exactly when they need it. So a little bit of this is repeat, but what we did was we started with the evidence base, which was having conversations with the HRIs, the hubs, those medical schools. We had conversations with doctors, and we learned, just like we had expected to learn, that the way to influence their behavior is to show up in their office, very similar to the way that a rep does. And that is the learning that we took, and that was some of the research that got us to that point. Our timeline is, we've been working on this now. This is the first 2 years, but we've been working on this now for 4 years. We did a lot of research to fully understand the program and what clinicians needed. We segmented, so we did research with OBs, pediatricians, family docs, the nurses, the physician assistants, each audience trying to understand what will influence them and what will help them. Then we created materials with what they said. They want videos, they want branded materials, They wanted to be able to reach out and call somebody quickly. And I think the common denominator that's applicable for this presentation is that they all said these one-on-one calls, nobody had a word for it. But it's in their words, when you call and tell me about this program, that really makes me interested in it, makes me want to use it. And there was actually just a paper released this week from the Access program in Wisconsin that shows that these interventions, these time-consuming one-on-one conversations positively impacts the number of times a doctor will call and access our programs, which is exactly what we want them to do. So that's the first paper from an Access program that has come out. So we were super excited to see that. So that is the timeline of what we did to get to the academic detailing in Heart. The way that we innovated it, and we're continue to innovate it, is we're a big state, and 12 medical schools is a lot of medical schools. It's a lot of doctors and we're trying to get the doctors to do the outreach to other doctors, the psychiatrists. So we have continued to need to innovate our messaging with them. To do different things. So to get them to do some of the different things that we want them to do in front of the outreach. So the first thing we did is to really talk to the clinicians about what the program is and how we can continue to get in front of different doctors. Then we really relied on the evidence base and showed them that there's a name for what we're doing. It's not just community outreach, it's academic detailing. This is what we're trying to do. And we want you to be better equipped to understand the needs, to understand the repetitive nature of needing to go back out, to build these relationships. Just like we heard in an earlier presentation, to have a relationship with everybody in that office. I have tried to say over and over again, and we're seeing that, like you make a relationship with whoever is standing at the door, the first person behind the counter that you come in contact with. Everybody has somebody that is having a mental health issue, and somebody needs to get to a doctor faster. So as soon as you can make that relationship connection and build that, then the sooner that we're going to have more doctors call us. We've also done a lot of training and technical assistance with NARCAD that has really been so helpful. I know I said Texas is big, but it really is like moving a program through an entire country when we adopted NARCAD, because it's like I have 12 different states in my one state, and what we're doing now is we're having a psychiatrist from each of the 12 medical schools attend NARCAD training. That's where we are at this point. I attended like almost 2 years ago, I think, the training. From that training, we were able to get the elevator pitches. We had our elevator pitches approved through 5 levels, and then we had them dispersed through all the 12 medical schools. Then we had meetings with every outreach person in the 12 medical schools to recite the elevator pitch, to know how to say it. Now we have a psychiatrist from each of the medical schools go to the NARCAD training. They go with that elevator pitch, and then they get to really have the experience of the training and learning how to do the role playing with the calls. And we see that this is really helping us. NARCAD has given us a North Star for me to be able to share with the psychiatrists and what they've done. Next slide. So like I said, our goal is to reach all pediatricians in our state. I want us to go to every single office, pediatrician office, every OB, every family doc, every health clinician, so they can learn about this program. And so NARCAD is essential and doing this one-on-one office interaction with the clinicians and teaching them how to call us and showing them what a call looks like has really been very helpful. And like I said, we have continued to see every month our numbers go higher and higher. We've helped thousands and tens of thousands of people around the state. So it's very helpful to us. And these are some of the participant quotes from the training that we've gone to. That it gave me tools that they need to be able to listen better to what the clinician is talking to them about. And it helped with their confidence. It's so interesting. It's hard, right? I mean, everybody is not an outreach person. Everyone cannot go and talk. And we kind of silly thought, well, if you're a psychiatrist and you talk to people all day, you can surely talk about this program to other psychiatrists. But it was a very vulnerable moment for people in our program, all different levels, from the community outworker to the psychiatrist, to start this conversation and not make it feel salesy. So I say to them before they open their mouths, I'm like, I just want you to picture for 1 second before you start talking that the behavior you're trying to create is going to improve a child's life. There's no question about it. This child is going to be waiting 3 months, 4 months to see a psychiatrist. And if they're a male child of color with ADHD, we can just see where that trajectory is going. And by talking to this clinician and saying, I can help you. I'm the psychiatrist that you're going to call. Just call me. I will help you with the prescription. You can call me every single time they come into your office. We have a 98% satisfaction rating, as do most of these access programs. Once a clinician uses us, they love it, because it is the curbside consult they're used to in medical school that they just don't get anymore when they're out of school and they're, constantly seeing patients. So these quotes echoed my experience as well. And I see it bubbling up like all around throughout our state with now that what we also require, once a psychiatrist goes to the training, they need to make a presentation to their outreach staff, and they need to incorporate whatever lesson they've learned into their outreach staff meetings and have people try it. So we're continuing trying to draw that out for them. And these are some of the materials that we have created. You can see there are 98% satisfaction, and we answered the phone within 30 seconds, sorry. You speak to somebody within 5 minutes. We text, and we do all these different things. But the skills that we've been able to gain and use in our academic detailing training and education has helped us get further in the door. There's still a lot of work to do for us. We still have, we have not cracked the magic of making a relationship with the office person so that they will further let us in and talk to the clinicians. And it's just, it's been super hard to get that one piece through, but we talk about the repetition and people are engaged with it, which just makes us super happy that they're doing it and that they're engaged. Thank you. That's a perfect one to focus on. So
thank you so much, Melanie. What a really cool and unique program. And I remember when you first reached out to myself and Anna and gave us your pitch about your program, trying to think, is this AD? And you really convinced us that it was getting evidence-based care, connecting to clinicians. And so it was for us a new way for us to wrap our heads around the model. Folks, we have time for 1, maybe 2 questions. We'll make sure you still get your full 15-minute break. Any questions on this great presentation from Melanie Sussman in Texas, connecting primary care physicians to psychiatrists when they need extra support? Thoughts or reflections? I know y'all are a little quiet today.
Oh, good.
So you're going to be stuck with Mike if you don't ask. Mike, I know you have a question, and Vishal, I know you have questions as well, that you've been thinking about kicking around for presentation. So let's start with Mike, and we'll go from there.
Yeah, Melanie, I'm interested in sort of when you're engaging clinicians, and this sort of relates to some of what Michelle was talking about in the connection between primary care clinicians and obstetricians. Here, it's sort of connection to mental health. I think sometimes it's hard when we're detailing, when people know the resources are so limited. They sort of, some of what Michelle was saying, people worry about, it's nice that you're coming to talk to me. You seem very supportive, but the system is so against me. How do you prepare your folks for that? Because you clearly got such positive reactions. How do you prepare people that you don't sort of get the brunt of the problems with the system and get them into a sort of a positive framing?
We just acknowledge the system. We can't start, especially in Texas, without acknowledging how the lack of providers that we have. But this program is so good that we know. So I say things like, we know that you have referred people and they wait for a long time because there's not enough clinicians. So what we can do for you is we will see the patient one time and offer a full psychiatric assessment and give you the treatment notes so that we can move them on their way. And if we feel like they're in crisis, then we will help with that as well. And we will talk to you every single time they come into your office while they're waiting. So we are part of the system because we are state funded. We're just like the Health and Human Services, and our budget is to be able to manage these is just part of it.
They fresh.
Ooh, need to mute there. Back to you,
Okay.
Melanie.
So we just acknowledge the system and the frustration, and we ask them, well, one of the things we learned in the training too was to really ask them, what is most frustrating to you about managing the mental health of your patients? And let's see how we can help and work together to address it.
Other questions? I know, Vishal, you had some up your sleeve as well.
Yeah, one that I was kind of thinking when looking at sort of that provider to provider relationship, do you tend to see any sort of territoriality in that zone? Like possibly I don't want to turf it over to this clinician or they won't understand what it is that I'm doing. Do you ever kind of see some of that in practice? And if you do, how do you respond to that?
We haven't seen it in practice because they're not doing it, honestly. It's not that they're trying to treat the mental health. It's more that they're just who's going to do this and where can it be? But what we do see is, and what we did here early on is we did not want to have an imbalance of a perceived imbalance of power that our psychiatrists were going to tell the general practitioners what to do. So the way that we try to break down that barrier is to have our psychiatrists do videos, be introduced in newsletters, go out to conferences, and be like, I'm the person you're going to talk to. And we often say that we use the term collaborate, and for your care. So we don't want to so we haven't seen any of the territorial issues, but we're conscious and we work very hard to make sure there's not a power dynamic between, so it can be perceived as the psychiatrist saying, this is what you need to do. And we go to great pains in saying, you always remain the primary. We just offer you treatment guidance.
I love that. And so really respectful of, the pre-existing relationships. Thank you for the Q&A time, Melanie. And thank you to Michelle, Deb, and Melanie for representing a wide global geographic scope from Adelaide to New York City to Texas. Really appreciate you all. If you have further questions, pop them in the chat. But for now, we're going to give you your break. Thank you for bearing with us as we ran over. Please be back at 3:40 Eastern, and we will wrap up with stories from the field, unique implementation settings. See y'all in 15 minutes. You can just shut off your camera and your mic, and we'll check in a little bit. Thank you. All right, welcome back for the final session of the third annual Academic Detailing Virtual Summit. We're so glad you're with us. Got a nice group of 40 people to wrap up the day, and we have some amazing stories from the field to share with you. We've really got a fantastic group of people. We've got a crew from Boston, but they detail in Pennsylvania and many other spots, and they're also good friends of ours. We've got a crew from West Virginia, and we've got another crew from Florida, and each one of these groups is doing really incredible quality improvement work in their respective areas, and just in such unique ways that are definitely ways we haven't yet heard of in the sessions we've had so far. So very pleased to turn it to Vishal to introduce this grouping and to introduce our first presentation. Vishal, over to you.
Thanks so much, Bevan. Welcome back. As Bevan said, we are super excited to round out with some stories from the field, some AD and unique implementation settings. If we think about sort of the focus of AD, the principles and the strategies are there, but what really is flexible is that ability to pivot and go to different locations. That means we're not always just in a one-to-one setting in an office. Sometimes we have to go where the work takes us, and we have to really ride the wind, as they say. And that could be anywhere from schools to long-term care facilities to nursing homes, even to other workplace sites such as casinos, hotels, barbershops, restaurants. Wherever it may take us, we can take detailing with us, and that's what we're really excited about. So, first stop we'll be making is over to West Virginia for Alicia Heil, who is the Special Programs Manager for the Rational Drug Therapy Program with the West Virginia University School of Pharmacy. She manages two programs there, the Academic Detailing Program, as well as the Managing Rational Drug Therapy Program, Safe and Effective Management of Pain Program. She is a wealth of knowledge and experience of everything detailing, and we're super excited to have her talk to us about detailing within school system. So without further ado, Alicia, take it away.
Thank you so much. It's wonderful to be here as always. Honored from last year and all of the updated trainings that your team has brought to our team, and just wonderful. So I'm glad to share some of the innovation that comes out of those trainings and the thought process afterwards. So this particular one, I think it's more focused on our subject matter. So it may not be applicable to everyone, but depending on what that subject matter that you're detailing is, may be super relevant. And actually, Jackie kind of gave us a really great plug for school nurses. So we'll be talking a little bit about that. But I have no disclosures to disclose. We are paid with grant funding, and that is just sort of our spiel. So as far as to give you a little bit of background about our program and where we come from. So I mentioned, or Vishal mentioned, that I manage the Safe and Effective Management of Pain program. And as a pharmacist, we did some academic detailing. We call it an technology-enabled academic detailing, and we implemented that into a prior authorization process for opioids and high-risk opioid regimens. And so that program was funded through CDC OD2A, Prevention for States. We've been kind of rolling with that. And it kind of led to this really great opioid stewardship program. And the folks that have been monitoring that under the Department of Health, where we get our grant funding, we're also monitoring kids for prescription stimulant use. And notice that in some of our counties in West Virginia, while we're seeing rising across the nation as well, but in some of our counties, we have these regional hotspots where almost 1 in 4 boys are on prescription stimulants, which is a really concerning number, considering they are Schedule II controlled substances. And so we wanted to take a statewide approach to ensure that folks were doing appropriate evaluation, diagnosis, treatment, anywhere from childhood prior to preschool or prior to school, preschool age, to adulthood, and making sure it's encompassed across the board. Our program is staffed with 4 clinical pharmacists, and they're on the call, and hopefully they'll share some of their experiences in this realm. And I am their program manager, in which I am honored to be here to kind of be the storyteller of their encounters, but really the work is theirs. So thank you guys. And then we have a program assistant who when getting creative, she is a great think tank behind the scenes in marketing the program with emails and whatnot. And then we have a data scientist, because when grant funding occurs, we need to show our outcomes, and we're really able to do great tracking and monitoring prescriptions via the prescription drug monitoring program and things like that. So next slide, please. So it wouldn't be a NARCAD event without some great chat waterfalls, and there's a beautiful waterfall from West Virginia. But if we could get started with sharing in the chat some supports, treatments, etc., things that people or children with ADHD may need while they are in school, or may need to have access to while they're in the school system.
All right, Alicia, you want me to read these, or would you
Yeah,
like to?
that sounds good.
Okay. Well, I'm just going to read my own now. Extra time to learn was the first thing I thought of as a former high school teacher with quite a few students who were struggling with ADHD or had yet to be diagnosed. So we also have rewards, differing learning style, learning organizational skills, decompression space. Yes, a quiet room to help with overstimulation, fidget toys, one-to-one learning, noise canceling headphones, counseling support, behavioral therapy techniques, more for comfort items, not just fidgets, but things like blankets, so texture items, accommodations like extended testing time and distraction reduced environments, says Nick from your program, and he knows well. So these are all incredible suggestions, and I just love that no matter what topic we're talking about, there are folks in the audience who know how to stand up for patients and what they need. Back to you, Alicia.
Yes, absolutely. So as you can see, there are a bunch, and that is on the treatment and support system. But even on the diagnosis system, there on the side of things, there can be things that we require or need from the school system. You can go ahead and go to the next slide, please. And so why academic detailing in the school system? As you can see from that chat waterfall, lots of things that we can implement to make sure kiddos have the best outcomes with ADHD. In our particular state, it varies really widely per county. And oh, you can stay on that, yep. It varies widely across the board. So we have nurses, social workers, counselors, psychologists, behavioral health therapists. We actually have school-based health systems in some of the areas too, where they have nurses, physicians, kind of integrating health into the educational system. But it varies because of the rurality of the state. And some of our counties, such as the one I'm currently in, which is Mon County, we sort of have a wealth of resources, but it is funded from a county level with levies that people vote on and put tax dollars into having support. So we have psychologists regularly within our school systems. Some of the areas we're detailing, they will report back that, they may have one psychologist that serves the entire county, and they may see them one time a month. And when you're talking about ADHD, we talked about all those supports to implement into IAPs, 504s, etc. But also, we really need that communication to occur with our clinicians and the school system to make sure there are appropriate diagnoses occurring. And medications being administered, with our school nurses. ADHD via the DSM-5 criteria should have symptoms within 2 settings. One usually is school. And so we want to make sure that those ADHD assessments are being completed accurately. And we've heard anecdotally in the field too, that there may be some of this, if you're not familiar, West Virginia has been hit very, very hard with the drug epidemic. We have the highest overdose death rates in the nation. And so our kids are facing challenges at home, in the school, have behavioral issues. And so they may be either forcing kids to be medicated with a behavioral issue. And like I said, we hear this anecdotally. We haven't found data to support this specifically, but maybe the teachers are forcing that to get them back, or filling out those Vanderbilts kind of I don't say inappropriately, but exaggerating the behaviors to help with getting those diagnoses. So we want to educate across the board and foster that communication between clinicians and the school system, as well as educating those within the school system on appropriate evaluation, diagnosis, and treatment of ADHD. So I always tell this to our detailers, don't just go walking into school systems. We don't want anyone to get in trouble with the security and whatnot going on in schools. So it's a different type, right? We're not just walking in trying to get past this gatekeeper. But what we have found that works for us is to utilize our funders. So some of our funders, as with Bevan, were past educators and able to make connections for us. We attend conferences regularly and build connections that way. We at Rational Drug Therapy, we get our feet wet in a lot of different projects and kind of just using that collaborative effort on anything we can kind of do to implement our messaging within the school system. And then nepotism, good old, use your connections wisely. Our director here has a sister, brother that are in the teaching system in West Virginia. Her mom is a school nurse. And so we've obviously utilize those connections too. Department of Education, we have county level and state level that we have leveraged, and we'll talk about that a little bit more. But utilize that, don't just go walk into schools. And you can go. Perfect. So our conference, this is Nick, one of our academic detailers. He's on the call today. And so this is just an example of one of our booths. And we actually utilize that time to do academic detailing at the conferences. Generally, it's during breaks and whatnot. They're coming up. We have plenty of our materials there. We may take the 5 minutes to go through it, or we may have a contact sheet that we can do future outreach or connect with others. We utilize this method at the school counselor conference, and we partnered that with speaking actually at the conference, and we were able to give a plug for ourselves. And so we just had a line that luckily we had 2 of us at the booth, and everyone was just coming up super excited for the materials. But it's a really great opportunity to get those out and target conferences that are speaking within the school system. And you can go to the next slide. In the same conference, or some of them, we have done. So we have an expanded mental health program, and they really just do across the board topics, but we were invited as part of those funding connections to participate in their summer webinar series. So Jonah, who was also on the call, and I did a 1-hour CE for them. And so that was a really great opportunity. I don't remember the numbers, but I feel like they probably had about 40 on the call. And then the one summer, it took some time working with the West Virginia Department of Education to kind of build a connection with the nurse at the state level. And she invited us to speak at the school nurses conference. And we had about 80 folks there, which was wonderful. And when I talk a little bit more about one of our connections, that was one of our other events was brought up at that and how wonderful it was. So it's just word of mouth within the system and just building that community. And this, I included a picture of Nick here, and I thought it was great that yours is the power of we. That particular conference with the school counselors was the power of you. And Nick did a talk on non-pharmacological treatments for ADHD. And if you can see in the background, there were literally folks lining up around the wall, sitting on the floor because everyone was very interested in the topic. So good job, Nick. And we can go on to the next one. And so in the power of we, academic detailing, right, is us getting the information out, but how do we really implement and receive feedback in the field and take it to the next level? So our folks were in the field, and again, West Virginia, super rural, super underserved, getting feedback that, those behavioral interventions sound wonderful, but where can I find them? There's no one near me. There's no one that provides that service in the area. So we kept hearing that, kept coming back over and over. And so we have this wonderful connection through a project of building these resources with one of our psychologists at WVU who specializes in this area. So we said, we'll host a session in the state. And so we hosted it twice, 2 different summers, one in Morgantown, one in Charleston. In total, about 120 participated. And as a result of that, one of the school psychologists here in Mon County invited him into Mon County schools to do a special workshop for them. And then he's been invited back year after year to continuously update them with new information. And they are both the other psychologists who invited him in. They're always very welcoming of keeping us connected and updating us. So it's really great. We've just built this whole community, and You know, we do, like I said, have resources here in Mon County, so I'm sure this is part of it with that levy. But Mon County school systems are constantly elevated and ranking pretty high in the state with all of their outcomes. So very excited to see this, and we can go on to the next slide. And so far we've been focusing on making sure that those today's youth are having those supports. But we've also, not just within that school system, focused on educating the next generation of healthcare clinicians. We can go on to the next slide. We've had multiple opportunities. You would think we would have some at WVU, but we haven't quite made it into their curriculum yet. But Marshall University and both Marshall University and the West Virginia School of Osteopathic Medicine have invited us in. At Marshall, we did a 1-hour talk for their psych residents, and we were able to get a lot of education material distributed to them. And then as far as the School of Osteopathic Medicine, they have been wonderful. We did a breakfast and learn for some of their residents, and we, I think, have 2 or 3 different talks. I know Jonah did one, and Ryan Archer, who's on the call as well. They just have been a wonderful collaborator. We went to conferences and build multiple connections. So it's been a really great opportunity. So that is a way that we have found to get into the next level of education, which we were talking about on the last one. And then I know Nick anecdotally has said that he in the field has experienced encounters where he has been out and the students have gotten the materials and they're calling and asking for more to give to their colleagues or their classmates. So that's been really exciting. But this has been a great opportunity. We can go to the next slide. And I left some time. I know we're kind of behind, but if anyone has any questions, but also our team is all on the call, so they can answer any questions, or Nick, Jonah, Ryan, if you have anything to share. And Stinking Caleb is in Hawaii, so he was not here today.
Caleb. Okay, that's a decent excuse. And that
Yes,
was
yes,
the
can't.
list of where people wanted to be transported to this morning or teleported to.
Exactly. I'm jealous.
Suppose that's fair. Wonderful presentation. Thank you so much. And would love to turn it, Nick, anything you would like to share? Jonah, Ryan, I'd just love to give you a moment to reflect on this project.
Yeah. So I attended the West Virginia School Counselors conference with Alicia, and we had a ton of interest from the attendees there. And as a result of that, I had gotten some sessions, booked with some schools like local to my area. I'm in the eastern part of the state, and it gave me the opportunity to learn more about what sort of interventions and approaches that counselors take towards ADHD, but also provide them with our evidence-based um, accommodations that we've identified in our guideline document. And overall, just served as like this really great learning opportunities from both sides that I think each party really benefited from. And it's something that, I hope that we can continue to do, in the future with, whatever capacity that we can.
Awesome. That's wonderful. And it was such a pleasure to have a few moments of a day or two to work with you guys on some techniques. And you guys are an incredible and yeah, you're a young team, and that's exciting because, and when I say a young team, like you're literally young. And it's exciting because, it's exciting to see folks coming out of school and like being interested in this work. And it's also just the camaraderie amongst your team is really palpable. Jonah, anything you'd like to reflect on?
Yeah, so kind of piggybacking off of Nick, I actually had the opportunity to detail at an elementary school. It was a school in the most populous county in West Virginia, but this particular school was kind of off the grid compared to the rest of the county, a very low income area, a very high prevalence of students with ADHD than I would say that your typical West Virginia school. And so they actually reached out because they talked to Nick at the conference and asked me to come and kind of detail a small group of teachers and staff. And so it was, your typical kind of AD session, except, these aren't medical providers. So I kind of had to put on that community pharmacist old training and make sure that everything was very appropriate to bring to them, to kind of keep away some of that medical verbiage and acronyms and stuff like that. But they absolutely loved it, and they've invited us back to speak to the entire school next year. So
That's
we're looking forward to it.
fantastic. That's wonderful. I'm really glad to hear all of that. We do have a question in the chat that I want to make sure there's time to address. And Alicia, you can decide, if you'd like to address it or if you'd like to kick it to a teammate. When providing educational resources, this is from Carolyn Weeks, for providers to share with parents of pediatric patients who are interested in alternatives to medication therapies, do you suggest or can you suggest a resource for these materials as well as stimulant educational resources?
Feel free, Nick or Jonah, to jump in. But for us, all of our funding has been for clinician education. So we recently developed our first patient focus. It's more parent focused resource, but we are just pointing them basically to CHADD, because CHADD is a great resource, and it has anywhere from patient to parent to clinician focused information.
Okay.
Thanks, Jonah, for putting that link in there.
Yeah, thank you. Anything you want to add to that, Ryan, Jonah, or Nick? Okay. Well, thank you so much, and we will be wrapping up. Really great to have you all here. You're one of our favorite groups. We'll move on to the next group in this unique implementation settings grouping of presentations. Vishal, over to you to introduce Alosa Health.
So excited to introduce some of our detailing partners at Alosa Health. We got Dominic Trombetta, Associate Professor over at Wilkes University, and Paul Fanikos, the COO of Alosa Health, here to talk to us about supporting older adults with Alzheimer's. Really excited to see this presentation about detailing in Pennsylvania and working with some of these populations in very unique settings. So without further ado, please take it away.
All right, over to you both.
Oh, well, thank you so much for the warm introduction, and it's always a pleasure to be here with everybody from NARCAD. So thanks for having us. Really appreciate it. I'm Paul, and you can hit the next slide. We'll jump right in.
That's all you got. I'm Paul.
I'm sorry?
I said, that's all you got. I'm Paul. I'm teasing you. I'm teasing you.
Yeah, that's it. That's all I got. Obviously, I'm here with Dominic. Dominic, is there more that you'd like to say? Maybe you can be more.
I'm just harassing you. I'm just harassing you because we used to work down the hall together. My apologies. Sorry. Back over to you guys.
Yeah, great. We have no disclosures to share with anybody, no financial disclosures. And we didn't use any AI to generate any pictures, content, or anything that you'll see here in this presentation. This whole project was sponsored by the Pharmaceutical Assistance Contract for the Elderly, which is part of the Department of Aging in Pennsylvania. And they've been great partners for many, many years. And we're really excited to be able to work with them and help some of their older patients. So that's what we got. Thank you.
All right, we got a chat waterfall for y'all. Imagine you have a loved one who has Alzheimer's, and this might not be something that some of you have to imagine, but let's just think about that. You have a loved one who has Alzheimer's. What kind of care or resource, and it can be multiple things, would you most want them to receive from a provider? Fill up the chat box with whatever comes to mind. All right, we've got compassionate care, 2 in a row, individualized care, patience, music. Thanks, Dave. Yeah, those creative juices flowing. What else? What kinds of care or resources? Feel free to put in as many as you can think of. Supportive care, have them feeling supported. Charles says safety, home health resources, empathy, patience, a calm demeanor, and non-argumentative. Empathetic and understanding. Mike says multimodal care. Support groups for their caregivers. Yes, that is key. Extra time in a visit, as well as you see we have kindness. Sorry there, I'm just losing my place. We have extra time in a visit, We also have referrals for caregiver support groups. We also have help with medication management, a safe way to get their medications, connections to their past, pictures, family, hobbies, behavioral mapping to assess for triggers. We love that. Thank you, Lauren from Canada. And then Nick from West Virginia says diligent care, without delay, consistent surveillance, supervision, and med management. So all great thoughts. Thank you for that. And back on over to you, Paul and Dominic.
Next slide, please. Yeah, so we looked at ages of people with Alzheimer's disease in 2025. 74% are 75 or older. So I think we're kind of seeing the aging of the baby boomer population. And the numbers are pretty staggering. That means about 1 in 9 people, or 11%, age 65 or older, have Alzheimer's dementia. Next slide, please. The mission of Pennsylvania Department of Aging is to promote independence, purpose, well-being in the lives of our older patients through advocacy, service, and protection. So everything that everyone mentioned ties into the entire message we were trying to talk about with providers. So it really resonated really well when speaking to providers, just listening to them and helping them provide resources and respite to caregivers that are taking care of their older parents or loved ones in their home.
Yeah, and Dom, one thing we really noticed when we started to dig into the data with the state was the change in the population over the next few years. The graph on the left depicts that change. We're going to see a large surge in the older population, and then it'll level out. But to really need to start to begin to prepare for this and things like access, transportation, education, caregiver support, all things that really matter, will need to be built in over the next few years. And the graph on the right depicts really where that age growth is. And, the blue line, the light blue line, indicates the people between the ages of 70 and 79. And we'll see a huge growth there. And same with patients over 80. So these are not young people. They're really much older than what we usually see in this category.
All right, we have another one. We have a poll here. It's going to be an ABCDE answer. So pop on over to your chat. As a detailer, what info would be most helpful to provide to clinicians caring for patients with Alzheimer's disease? So is it evidence on the benefits and risks of newer drugs? And these are all important, but what do you think is most important? Support and local resources for patients' caregivers. Some of you identified that already. Useful language around advanced care planning, and primary care recommendations that may reduce the risk for dementia. What do we think there? And we have a secret answer here, all of the above, which we know all of these are very important, and Paul gives away the answer, right? So, and really, yeah, we've got a lot of folks saying, E, but also there are certain places where you might start as a detailer. You might start with, I see some people saying A then D, B then D. So it's important to think about how many different kinds of resources you would need when you're caring for this specific population. All right, back over to you.
So it was very meaningful work and rewarding to help primary care providers provide this useful information on the services, programs such as home delivered meals, caregiver support, farmers market vouchers, health and wellness services, personal assistance, transportation to doctor's appointments, PACE prescription assistance, active adult center activities, again, for respite care. Our task was to share this information not only with primary care providers, but the entire office staff, medical assistants, nurses, other appropriate office personnel, so that this way it was a real team effort and that they can help educate patients, family caregivers to what exactly, what assistance is actually available to them based upon their particular needs. So it really was pretty helpful. And when you talk to providers, this is what they wanted to talk about. This is what they want to know about. So this was I think our materials were really spot on. And of course, we had to do our community research because every community was different in terms of what their centers provided and what was actually available to them in that particular locale. Next slide, please.
Yeah, so when we thought about the project, we, went in with the traditional academic detailing approach, where we were going to go to the sites. We did this mostly in person, some virtual, but mostly in person, to discuss these topics with clinicians and their staff. We wanted to identify what gaps that were happening, either with the medications, but also with the services that were provided or not provided to patients and caregivers that were not offered, that might be free or low cost or readily available in the community. And then obviously we wanted to backfill those knowledge gaps with the resources that would do that most effectively. As part of the project, we targeted originally about 3,000 offices to work with. And we got into about a third of those, which was pretty good. So we had about a 33% success rate. And ultimately that allowed for over 1,000 prescriber encounters and with their staffs on this topic. And obviously, like Dominic said, it was very, very well received. And we did this through working with the state to identify where these locations were through the data that they had. So we didn't go blindly into it. And then what we wanted to do was offer it throughout the state, and we were able to do that. This graph depicts where we were able to go and see providers across the state. And you can see like two kind of hubs, right, in Philadelphia, that area and around Philadelphia, and obviously Pittsburgh. But we have a lot of older adults, in what I would call the space in between. Some people would call it white space, but we had a lot of patients in the rural areas, a lot of physicians in those areas that needed support as well. So we were able to have a great amount of headway there too.
So tools we had an evidence document, we had a summary brochure, a patient brochure, a reference card, and tear-off, and all these are available on the Alosa Health website as well. So really a lot of excellent information to help our providers as well as their staff better assist their patients by actually providing the resources. We had QR codes for support and finding support and help for patients. So I think that we were very spot on with the materials that they were engaging as well as helpful. So some of the key messages that we had were, things like, okay, so I have a patient in front of me, but there's not much I could do about the reversing the course of their illness. But what can I do for all the patients on my panel so I can minimize their chances of developing neurocognitive impairment secondary to Alzheimer's? Things we talked about was controlling blood pressure and considering Mediterranean diet, using the evidence to demonstrate this information. Talking to them about, well, how do you assess dementia severity? Do you use a tool like a mini-cog? Talk about reversible causes of cognitive deterioration, medications that have minimal impact, namely the older cholinesterase inhibitors. Talking to them about what the new medication options are. Identify reversible causes of behavioral and psychological symptoms of dementia, and beginning those very difficult conversations about advanced care planning and supporting caregivers to maintain their own health and encourage self-care. Next slide.
Yeah, so I'll
Back
take
one.
this one.
Yeah, okay. All right, so medications, again, with meaningful impact for patients with Alzheimer's is really years away. So that was kind of the message. But I think we did provide a lot of hope and invaluable information that providers were actually able to translate into helping their patients. I'm sorry, go ahead, Paul.
Yeah, I just would add, Dom, obviously one of the things we were trying to do was the medications that do cause harm in older adults, that to try to use them sparingly, or if not at all, and what were some helpful alternatives that would maybe get the same result without any of the side effects. And somebody mentioned this a little earlier. I saw it in one of the tabs, and it was, caregiver support. And that's obviously a really large piece of the project. And the more we did it, the more we found out that was what was needed too. So we had built a few tools, specifically Dom had mentioned them. People didn't know about them. They were like a best kept secret. They're on a web page, but no one can find them. There's so much information, they didn't know where to look. So they really appreciated a quick reference tool that would help them get to these items really fast, and that they wouldn't have to dig through a desk drawer or find a phone number that they couldn't seem to locate. It helped really streamline their process in managing some of these difficult conversations and interactions. And one part I would just suggest, and it was a nice takeaway for me and learned from Dom and obviously the other educators as well, and that was when you're having some of these discussions, that would be to have them towards the end of the day, to plan for them. In other words, don't schedule this conversation right in the middle of the day, because it's going to mess up everything else that goes along. It's going to take a lot more time than one would expect. So, talking about advanced care planning, how to get in touch with somebody, for transportation, or maybe some support around food or medication, those things take a considerable amount of time. So building that into the dialogue and helping people, plan for that makes a big difference. And the educators were, keenly aware of that. Dom, I didn't mean to steal your thunder on that. I hope I didn't.
Oh, that's okay. That's okay. So these are kind of the local resources that what we did was, before we began the module, we start looking at, well, what is available in our community? So we had to contact the active adult centers, talk to them about what kinds of programs, services that they provided. And we provided the PA MediLink programs for prescription assistance, caregiver support programs that provide respite care to allow caregivers to maintain their health and wellness. And also things that we always have to be cognizant of as providers and reporters is elder abuse. And what's even growing that we began to recognize when we start doing these modules is actually the older grandparents providing care for grandkids. So not only are they, we see a lot of them going back to work in a mature worker program, but also providing direct care to their grandchildren. So we kind of made all these resources available that many of them were unaware of. And again, the home delivered meals, best kept secret, that they were able to provide through the local area agency on aging. Next slide, please. So Paul, do you want to take this here?
Oh yeah, sure, John. One of the things we did is, from those thousands of visits that were done, the educators and academic detailers will type notes. And what we took is we downloaded all the notes, and we were specifically interested in what popped up most frequently. And these were some of the items that people were really interested in, and we're having a lot of dialogue around. So obviously, improved care for patients, better conversations about how to manage the disease, and obviously the items that we already referenced about the support for caregivers. And those were the things that they clearly wanted, and those were the things we were actually most of our conversations were about. And we dumped it into a word cloud, Bevan. I know you love a word cloud, so we did it. And we took that from Bevan. We said, how can we make this more interesting to take a peek at? And so these were some of the things that popped up most frequently. Long wait time for specialists. So clearly this was very helpful for primary care doctors about how to manage patients along a spectrum, how to manage screening, and how to do it really effectively. What medications you can use for patients that might have, some anxiety and things like that. How do you do it in a way that's safe for them? So we hit on that. And then some of the items that were really clear that we saw was post-COVID was obviously isolation and social issues with older adults, social isolation, a huge issue. So connecting older adults to those types of tools and resources really meant a lot to them, and actually went a long way to helping the physicians and the caregivers. When we surveyed the prescribers post-visit, we did about blind surveys. We sent them out, and we had about 100 prescribers respond. And we were looking at, some specific change behaviors, but also how well did we do in our work or engagement. And some of the things that I thought were really interesting is we scored really high. So that means the topic was really well received. This is a Likert scale of 1 to 5, and we almost hit 5 on almost every category. So we're really happy with that. But the ones that we wanted to take away most frequently with was, number 4 was really where they were able to have better conversations with patients and caregivers, and that was really high. So very proud of the project, and we can tell from this survey that it was, again, well received, and the material is clearly helpful for their work.
All right.
There we go. Okay.
Yes, if you want to do that, go right ahead.
So as far as when talking to providers, 2 things that they had in common that they kind of all talked about. And I'm really not going to talk about the second one, being overwhelmed by algorithms, because unfortunately, I think we bring them more than we take away. But I think compassion, and I think that's really obvious. We all know that our providers are empathetic, compassionate, and they demonstrate real concern for their patient, but they also have the desire to take action to improve the quality of their lives. So I think that with this module, we provide them with the tools, the evidence, and the resources that are valuable to them and the patients they serve.
All right. That's a wrap. Thank you so much to our colleagues from ALOSA. What a meaningful program. And just to call out again, I love that your presentation started with asking folks in the audience how they might attune, how they would want a patient that they cared about with Alzheimer's or dementia to be attuned to. And then later on, having folks sound off on the best resources for providers. And there was so much synergy there. And also just, again, those Likert scale scores were really beautiful to see that the impact is just so clear. So kudos to you both and the rest of the team on that. Would love to open it up to questions. Again, don't forget, even if you're not working on Alzheimer's or on any interventions that impact older adults, there's a lot of crossover here about taking care of patients who need community support, who need family support, for whom caregivers need support as well, and for whom taking care of these patients is medically complex, and where clinicians really need the kind of attunement and evidence that ALOSA was able to bring to them. So open to any questions, and I know there's always some from our home team, so it'll be on all y'all if we start talking again. Please pop them in the chat. Otherwise, I will turn it on over to Mike, who I know always has questions about the richness of your work at ALOSA. So over to you, Mike.
Yeah, I'm really interested, actually, sort of in a connection between this and the presentation right before it from the team in West Virginia. I was struck with the school presentation. Those kids, they spend so much of the time in school. They see the behaviors there, and there's sort of the interaction between what's happening in the school setting and what's happening with their pediatric providers. And I'm interested here, a lot of the challenges you might see might be for, depending on where an older patient is in their progress with Alzheimer's or another condition like that. They might be in an adult day program, they might be in an assisted living, maybe they have some caregivers who come into their home, and as a clinician, sort of wearing my primary care hat, we get the occasional report about it, or they're a little, maybe a little, agitated, their adult day program. Have you thought about sort of ways to do something like what the West Virginia team did, or I'm curious what you think of that idea of, getting into the programs where these patients spend most of their time and where their symptoms kind of manifest. It's not the classic model, of course, Alyssa, you have all these deep relationships with the doctors and the NPs, the prescribers, but I'm interested in that sort of, that dynamic of getting outside the office for these chronic behavioral conditions, the same way that the other team was talking about doing that for pediatric patients.
Mike, do you think you could synthesize your question? Because I'm also trying to grab it for the chat into.
Oh, sure. Do you think that you might, are there ways you've thought about or might think about complementing what you were doing in the medical offices with detailing in the other settings where patients with Alzheimer's get their care?
Yeah, that's a great question, Mike. I think there'd be some high value there. In adult daycare centers, things along those lines. So we do some work with, and Dominic can speak to this, with the local Department of Aging, but we could clearly do more. And it's probably really more a matter of funding that stops us from doing some of that work. If we were able to squeeze some more dollars out of it, we could spread more people. But I would say that the funder in general has been open to us doing on a topic like this to go a little wider, and then traditional work with healthcare practitioners specifically or only. So I think that's a great point, that we could point out other areas where we could bring value of educating people about the disease, what resources are available. And you bring something up that I hadn't really kind of considered, like how to approach it. And now that I know that West Virginia has done something a little different, I've learned something as well from being here today. So
Wonderful.
yeah,
Don't act so surprised.
No, I'm not surprised. It's just funny that it was right before this one, right before this discussion.
Yeah.
So
well, that's the beauty of Anna, who's not here today, planning to pull these presentations into the right slot. So the synergy there was definitely preconceived, but it's a great thing to think about. How are we meeting patients where they spend their time, and also links up with the pharmacy presentation from yesterday, thinking about where do patients have access points to care that are outside of the clinic setting.
Yeah, and I would just say there was two things that we did some work. One was with a group of case managers, and the other one was with an association for medical assistants. That there was an association there that we did some training and development work with. So it was kind of touched on it, but not quite to the level that Mike was hitting at.
We have time for one more question, and we have it from Lauren Regier in the chat. Thinking about and wanting to know, with such high Likert scale responses and just seem like customer satisfaction, was there any pushback? Were there any barriers? And if so, what did those look like? What were some trends there?
I'll let Dom handle that one.
Dom, what do you think?
He was front and center dealing with that.
Thanks, Paul. Well, I think when you go back to the surveys, I think one of the lower scores was, will this change your practice? And I think a lot of physicians answered that in terms of what they're doing as far as drug therapy, because I think one of the things we highlighted is, okay, there's limited value to the older medications, but did you really think about the newer medications, the side effect profiles? Were you aware of them, since this is primarily something you're going to send to a neurologist for? But did you think through the logistics of having to get a patient with Alzheimer's disease to a infusion center every so often, or even how sending them for serial MRI scans very frequently, so it's just something that I think that what they really thought about I think a lot of them took a step back and said, I don't really think I can be doing anything differently but using the older medications. But I think that, from my perspective, they still really appreciate what they can really do for their patients in terms of caregiver assistance, maintaining the health and wellness of the caregivers, keeping patients in their home as long as possible. As Mike alluded to with behavioral symptoms, I think it can be extremely challenging, but just empathizing and understanding where they're at, and just trying to offer assistance where we can was very meaningful and appreciated.
That's wonderful. Lauren, anything you want to add to that, or just the thumbs up? Thumbs up. I know Lauren's done a ton of work in long-term care and thinking about all of that. So that's great that was what they saw as a barrier, like wasn't that it wasn't meaningful, that it that there was so much meaning. So again, congratulations on such a successful campaign, and thank you for being here.
I want to thank everyone for hanging out to the very end.
Yes, well, there's one more. We've got
okay.
Florida Department of Health in Broward County. I'm going to turn it to my fantastic co-host to do one last introduction for this event. Vishal, over to you.
Thank you so much. We are super excited to round this out with the Florida Department of Health in Broward County in Southern Florida. We have 3 individuals from the Overdose Data to Action, or OD2A program. We have Alexandria Stevenson, our lead health educator. We have Johanna Lucas, an academic detailer and health educator, and Jordana Petit-Homme, an academic detailer with the program, here to talk to us about OD2A in Florida. Please take it away, ladies.
Thank you so much. I'm glad to finally get to present, getting ready for, such a great wrap up to this summit. So yeah, I know OD2A has been touched on a little bit before. I know there's some other counties and programs that have talked about it, but basically we were awarded this grant in August 2023. It was actually a continuation of the previous grant in 2019. And basically it's funding a lot of Broward County's overdose surveillance, which in turn guides our targeted and effective prevention activities, such as our overdose fatality review, and of course, our program, our academic detailing. So next slide. So a little bit about Broward County. It is almost a rectangle. It is about 1,300 square miles. Only about 471% of that is developed land. When the county was created, it was actually named Broward County from a previous governor who actually wanted to drain the entire Everglades and make it all developed land. I'm glad that he didn't, because we only have that small area and we still have a lot of work to do. But as you can see, the majority of our county is comprised of the Everglades Wildlife Management Area. You could see the Miccosukee Indian Reservation along the western border with Collier County and Naples, Florida to the west. And our activities are mostly actually only happening in the eastern portion. All of the roadways making a huge maze there. We've got major highways, Interstate 75 and I-95 We have I-595 connecting them, along with some highways and toll roads. So we do have a lot of connections to the western portion of the county, of the state, and also connected in the south to Miami-Dade and in the north to Palm Beach County. Even though Broward is physically smaller in size than either county, to the north or south, our population is just under 2 million year-round inhabitants. So it is actually the second largest county in Florida, right behind Dade County in Miami, as well as one of the largest counties in the nation. So it is, there's a big majority minority county. So we do have a lot of folks living here, visiting year round from other places, but we also do have a lot of residents full-time speaking other languages, most commonly Spanish, especially with our proximity to Miami. But we also have a lot of people who speak Haitian Creole, Portuguese, as well as Russian in some areas of Broward County, and tons of other languages too. We've adapted many of our patient education flyers to Spanish, and we are currently working on developing more in both Haitian Creole and Portuguese. We are fortunate in that our academic detailing team has native speakers for Spanish and Haitian Creole, and our larger OD2A team also has plenty of Spanish and Portuguese speakers as well. So next slide. So pivoting a little bit to opioids, our work is largely on, academic detailing, health education for the opioid epidemic. Broward is particularly hit hard by the opioid epidemic, both historically with overprescribing and pill mills in the late 1990s, early 2000s. Fentanyl has hit here pretty hard as well. And as you can see, the fatal overdoses in Broward County, this goes back to 2015. Almost every year, at least 75% of all overdoses, fatal overdoses happening in our county, involve opioids, either in some way, maybe polysubstance use, but also sometimes as just the sole drug. So in that, next slide, please. So with that, we do have a lot of work that we do. Of course, your traditional academic detailing with healthcare providers in the healthcare settings. We did a total of 100, well, over that now, over 200 now, initial first visits in this past year since I had both Johanna and Jordana start. So we've also done webinars and trying to get the greater network of providers in our community on these webinars about various topics. We hosted our first one in April, and we hosted an ARNP who discussed buprenorphine induction in primary care settings. We also visit our local nursing colleges as well as fire academies to speak with, EMS and paramedic students. We do presentations with medical centers, depending on what they're looking for. Sometimes it's training on CDC guidelines for opioid prescribing. Sometimes we also do naloxone presentations when we're able to bring them Narcan and show them how to use it, leave them some for first aid kits and whatnot. And we also started branching out this year to different organizations and companies. It actually started with them approaching us. Oh, and we also attend community events, as I put here. The total number of naloxone that we've distributed from our community events has been 641 kits. As I said, these numbers were from mid-April, so I know we've done over 700 now. So that's well over, that number for doses as well. I can't do the math right now, but next slide, please. Did I freeze?
Oh,
Oh.
I'm not sure. No, this slide is up.
Okay.
Year 2 highlights. Yep.
Okay, yeah. Okay, so next slide now. All right, so we just talked a little bit about naloxone in case you're unfamiliar with it. It's basically the medication designed to rapidly reverse an opioid overdose. It's not a substitute for emergency medical care, but it can help restore normal breathing to somebody whose either breathing has slowed or stopped due to opioid overdose. And what we usually will let people know when we visit is that, if we have it, we will give them boxes that we have, but we also leave them with handouts talking about where to get it. And I'll let Johanna take the next slide.
Okay, thank you. Johanna, are you with us?
Yes, next slide, please.
Okay. Just a moment. We're having a glitch here. There we go.
Oh, back one slide. Yeah, perfect. So in Broward County, the Florida Department of Health, we have 2 locations, 2 pharmacies where we are able to give out naloxone for free. So we have the Fort Lauderdale Health Center, which is our main campus, and the Paul Hughes Health Center Pharmacy, which is in Pompano Beach. So people, family, friends, if they're not so people and family friends, they can go to these 2 locations to get naloxone for free. They just have to be 18 years or older, and they don't need a prescription to get naloxone. But for instance, if these 2 locations are not accessible for them to come by bus or even by car, we give them another location, not another location, but another website called isafeflorida.com, where they're able to see different organizations, different businesses, and also different health departments throughout the state of Florida, where they're able to pick up Narcan for free. So like Alex said from before, Narcan, we're also able to bring them to academic detailing sessions, presentations, and also health fairs.
All right. Yeah, so actually how this all started, as I mentioned a little bit earlier, we had a company reach out to us, and it wasn't our typical request for presentation. It was actually from a construction company. So they had a lot of, I guess, substance use, within their company or overdoses. So they wanted us to come and do a safety presentation. So in looking into it, I realized that construction has one of the highest rates of substance use. And so we actually partnered with another organization, the Robin Foundation, which we'll talk a little bit about more in a couple slides here. But we met with Robin Foundation to bring them Narcan, to talk about it, how to use it, where to get it, and just why it's important to have, a little bit about substance use, a little bit about stigma. So everything that we would normally talk to healthcare providers about, but adapting it for, safety companies who are interested in the safety of their employees. And so it kind of opened a new area for us. And of course, we have here other presentations we've done. I've attended various task force meetings. Our OD2A program is nestled in our community health department for the Department of Health. And so we meet a lot with our other programs, and I've spoken on, opioid safety with task force meetings that they'll have with, the larger county. And through those meetings, we've also connected to Broward County government officials. We have also spoken to presentations at halfway houses, as well as businesses. So, in addition to the construction, we've also reached out to restaurants, hotels. I've walked into barbershops that may be, in a shopping center next to a healthcare center. Casinos, we have a couple here. So we've gone to one, and just speaking with their safety. And at all of these, we're definitely emphasizing, the naloxone information, distribution. Basically, we tell them we will drive out and we will we will get you some. All right, so okay, I'll turn over to Johanna.
So, in Broward County, we really believe in collaboration. We believe that collaboration is key. So partnership plays an integral role in guiding our outreach strategies. So in Florida Department of Health in Broward, we collaborate with public and private agencies across multiple sectors throughout Broward County, such as harm reduction, law enforcement, social service, healthcare, and behavioral health. Like Alex mentioned, one of our biggest community partners is the Robin Foundation. So the Robin Foundation was co-founded by Chris Cavallo and his daughter Christina in memory of Robin and Stephanie Cavallo, mother and daughter who passed away by overdose. The Robin Foundation's vision is to create a community where lives are saved and transformed through the provision of free Narcan, comprehensive training, and ongoing support to those at risk of overdose. So recently in the month of March, we partnered up with the Robin Foundation and also the fire departments in Hollywood Beach and Dania Beach. We visited restaurants, hotels, motels, resorts, and dropped off boxes of Narcan, um, at these locations, educational brochures and pamphlets, and discussing on how to recognize the signs of an opioid overdose and also how to administer naloxone, since in these locations you typically find a lot of overdoses that happen. So this just was a prevention tactic done to reduce the risk of a fatal overdose from occurring in these locations. So it was a great way to partner up with our community partners and to help reduce the numbers of fatal overdoses that happen in Broward County.
Okay, so it is through our strong relationships that we are always constantly are being made aware of the various events happening throughout Broward so that we can participate and just connect with our community. So tabling, it serves as our primary mode of community outreach, and it just allows us to conveniently reach the community within the community. So we meet all types of different individuals where they are. So at tabling events, we really focus on fostering conversations around naloxone as well as opioid safety. And we just get the opportunity to hear more about perceptions. We get the opportunity to address stigma as well as misconceptions within the community. And because we're continuously meeting with a wide range of individuals, all the insight that we gain, they're very valuable, and it just helps to deepen engagement as well as inform our outreach materials to make them more patient centered. So each month we strive to attend at least 3 community events. We typically do additional events, but it varies whenever we have the availability. So, how do we choose what events to attend? So, we're pretty open when it comes to attending events. We try to go to as many events as we can, as OUD, opioid use disorder, or even overdose. It can affect anyone. It could be us personally, someone we know, or it can be a situation where we're a bystander and it's a stranger. So, regardless of the event, we're willing to adjust and tailor the material to meet the needs of the target audience. So specifically in Broward, so many of our local healthcare systems, our churches and city departments, they host health fairs as well as family fun days. And it's just a way to link the community to local available resources. So specifically to our health fairs, at both events, we distribute naloxone and discuss just opioid safety, overdose prevention to those interested. But specifically at our health fairs, we noticed that it's also an opportunity to connect with the providers and healthcare professionals that are at the event. So when going to these fairs, we do reach out to the providers, and we have even done sessions right there at the event, or we've gotten the opportunity to schedule for a later date. Next, we have our community baby showers. So this is just a unique way to connect with expecting mothers. And through these events, we provide educational resources about the risk of using opioids while pregnant, as well as managing medications with their providers. Next, I can briefly speak on our youth events. So those are some of my favorite events to attend. So with our students, we really focus on fentanyl awareness, and we really place an emphasis on counterfeit pills. So when we're in school at an in-school event, we cannot give the children Narcan because through the Florida Health Department, you do have to be 18 years or older, but we do provide valuable education as well as resources for the students to contact for any additional substances. And a new initiative that the Broward County School Board that they've recently been implementing are town halls, where in various cities they bring in parents as well as students together to start the conversation about mental health and substance use. So since the year has started, we've been able to attend 2 of these town hall meetings. And the one that I attended personally, it was a great opportunity to speak with parents as well as students as well, talk about fentanyl awareness, talk about counterfeit medications. And the focus of that summit was social media's influence on teens. And lastly, another main event that we participate in is our Broward Sheriff's Office Reentry Educational and Employment Expo. And those expos are for individuals who are firmly incarcerated, and they also have an annual homeless community symposium, and that just provides resources for individuals experiencing homelessness. And those events provide us with unique lived experience, which is very valuable to incorporate into our detailing efforts. So through those events, even I myself, I'm continuously learning things. For instance, I'm learning different substance names, different ways that individuals are trying to verify if their substances are pure prior to using them. And most importantly, we're always becoming more familiarized with organizations that continuously help support individuals with substance use disorder. And with that, we continuously add those organizations to our local resource guide so that we can give to our providers, or we can refer it out to individuals who reach out to us to learn more information about that stuff.
Awesome. All right, we have just a few minutes left. Alexandra?
Oh, I think you're muted, Alexandra.
You are muted.
I'm sorry. I'm not seeing the slides.
You're seeing them now?
Oh, yes, yes.
Good.
Yeah, so in all of the outreach we've done, I know Jordana just went over a lot of it, and yeah, so in all of this, we're continuously learning, we're continuously adapting, and one of the major things that we had to do very quick, especially in the beginning, was adapting key messages, knowing our audience, and knowing the pushback and types of stigma that we might encounter. Of course, when we're speaking with clinicians, there is pushback and stigma, but there might be different things that you didn't even weren't even aware of that will pop up when you're speaking with the general public or students or a senior center. So there's different things that we are constantly adapting to. One thing that we do like to do, as I think just as the Department of Health in general, our community health, is knowing our resources, our partners, being able to have information available in the various languages spoken in the county, and understanding that there are language barriers that we may not be able to overcome. Luckily, our team, I am fluent in English and Spanish, and we have other members on our team, Johanna and Jordana, who are fluent in Haitian Creole as well. Above all, I think expecting the unexpected, because it will happen. So with that, we definitely try to connect with local organizations, both city, county, nonprofits, and other organizations. We like our handouts to be as clear as possible. They do go through a process to ensure that they are looked over to make sure that they're accessible as well, with the colors and with wording and things like that. So we want them to be very easy to understand and very accessible. Currently, we have most of our CDC materials that we have from the grant in English and Spanish. We are working to adapt some of those as our own into, of course, Haitian Creole, and hopefully Portuguese in the future. But just being very familiar with our resources and just knowing, meeting people where they're at, knowing how to help somebody, doing, a very, very quick needs assessment as part of that, and just seeing, what is their problem? How can I help them? And yeah, I mean, with that, I think we're pretty much done.
Thank you so much to all three of you, and I appreciate you including your contact info. We'll make sure that everyone gets it. And we did drop the Robin Foundation in the chat for those of you who would like to check that out. We have time for one question before we wrap up. So if anybody would like to throw a question to the fantastic Florida team in Broward County, now would be the time. Vishal, I know you have one ready to go, and if anybody else would like to drop something in the chat, please do. But Vishal, take it away.
I sure do. So when looking, great presentation, by the way. When looking at developing a lot of the programs, especially working with, sites off that maybe necessarily aren't familiar with Narcan or haven't had a lot of exposure, how do you kind of break through a lot of maybe policy inhibitions if, people are kind of worried about legalities of it, or that's kind of what they're hung up on? How do you sort of work to get them past that?
We talk a lot about Florida's Good Samaritan law. We talk a lot about reminding them that they can also buy it. If they're not comfortable taking it from us, they can buy it over the counter at pharmacies here in Florida. But mostly we talk about just breaking down what Narcan is, how it's used. We talk about, it's without trying to get too scientific, how it works. Sometimes people think, oh, well, can it get you high? Or, is it going to be something that encourages someone to do drugs? So we come with the facts, we talk to them about what it is, and just, very much on that educational and, all the research and things done on it.
That's excellent. Just thinking about the fact that stigma is often not based on evidence, right? So bringing the facts to kind of start bringing the sort of mold of stigma into the light of evidence can kind of break that down and help people learn and break down their misunderstandings. Excellent work. Thank you so much for being here, ladies, and for wrapping us up. All right, we're going to wrap up. Thank you so much to all of you for being here over these last 2 days, whether you were here the whole time or you were able to kind of step in and out for the sessions that were most meaningful to you. We are so grateful to have you here, and to all of our phenomenal presenters. I know that each one of you took time to really, really stop and craft a presentation where you really thought about, how can I distill some of the things that I and my program have learned into digestible nuggets and bring them back to, have folks be able to bring them back to their individual programs and apply them. It's all well and done, well and good rather, to, have presentations where great stuff happens, but how do we translate that, especially during a time where we have such few resources, or we don't know what our resources will look like in the very near future. We need to know that we can learn from each other and take things and turn them into tangible tools for little to no cost. So we're going to put all of the resources up. My goal is to have them up actually by tomorrow, if not Monday. I will send you all a quick alert when they are ready to go. So nothing that you need to do at this point. Every single link that Vishal and I and other folks have dropped into the chat will be on one page for you within the next 24 hours. So if there's something you missed, you didn't get a chance to grab it, we've got you. You'll have recordings of all the main sessions, and a few of the breakouts were recorded. If there were any handouts or resources shared in your breakouts, those will also be available. So stay tuned. Over to you, Vishal, to talk about evals real quick.
Thanks. So we'd love to hear how we did, ways that we can continue providing great services to you. So please be sure to fill out the eval forms. If you did not fill out yesterday's, you still have a chance to do it, as well as fill out today's form. So that is in the chat right now.
We'd be super grateful if you have a second to open that link and just even start so that it's fresh. We all know that once we are a few days down the road from an event, a doctor's appointment, whatever the case may be, it's harder to kind of capture what went well and what didn't. And we really want to know, we really, really do take constructive criticism and implement it into our future events. So while you're taking a look at that link, here's a couple quick promotional pieces that we think will be most useful to this particular crowd. So if you want to check out our NARCAD.org main page, you will find a lot of good stuff here. We do have a training coming up in just a couple of weeks, and there's a couple of spots left. So Vishal, why don't you talk for a quick second about that?
Yeah, the trainings are so much fun. As a training facilitator, it's probably one of the things I look forward to most few times throughout the year. It's a 3-day training all about the basics of academic detailing. So you'll go in there not expecting anyone to become an absolute expert, but at least get the journey started and really get a good grasp on the philosophy. And it's a lot of fun.
It is. There's a lot of role play, and people who love it or hate the role play still say in our evals that it's the most helpful piece of the journey of training with us. We also now offer personalized coaching sessions, literally anything you need. If you want to spend an hour and just do a role play where one of our staff members plays a crusty clinician and you just need to practice sticking to your key messages or dealing with behavioral and attitudinal pushback, we can do that. If you want to spend an hour talking about evaluation, we can do that. If you want us to help you figure out how to build a detailing aid, we can do that. So that's in the chat box as well. We also have some pretty cool core toolkits. Ooh, that's tongue twister. Vishal, over to you.
So, interested in learning about how to develop an academic detailing program or add to an already existing program? We have a whole list of great curated resources to help you build programs on specific detailing topics. So please be sure to check us out at this link here on AD Toolkits and just explore. We like to reuse a lot of materials and really help each other out. So take a look at what's been done and how you can sort of make it your own.
Yep, and especially given all of the cuts on DEI, we still are rocking and rolling our inclusivity toolkit, and that's not going anywhere. So please check it out and see if there's any ways that our work on bringing inclusive lenses into detailing visits can be helpful for you. We also have a new this year program called Skills Lab. It is less than an hour, and there are episodes where you can put them on and learn concrete skills, such as how to build a detailing aid for next to nothing, how to recruit and train and retain the best detailers. So do check that out. A couple more quick things. Vishal, what about our podcast?
We have an incredible podcast called the Changing Mind Podcast, now available on Apple and on Spotify. We have so many great topics, so many great interviews on there. I personally do listen to them when I take road trips, and they're always really inspiring, really fun to listen to. Just great, easy listen. So highly recommend checking it out, whether you're on the go, in the car, at the gym. You can definitely enrich yourself with some great detailing.
Amazing. And Zach Dumont in Canada says it slaps, which I think the youth say when something is good. We're also going to have our friends from Dish, Arizona on the next podcast for Pride Month as we wrap up the month. So please keep an ear out for that and like and subscribe. And almost last but not least, please join us for more community connection. You don't have to wait until the conference that's coming in November. You can join one of our virtual community check-ins. It's a vibe like this, but there's no presentation so much as a conversation. The next one is July 16th, and you will get an alert when registration opens. And here is last but not least, we'd love you to come to our virtual conference this year because we know that funding is always so challenging. And in particular this year, we want you to be able to afford to come and not have to fly and be away from home. So we're going to do a virtual conference this year. Please do join us, and more information will be available in the summer. I'm going to turn it to Mike for some closing thoughts. Thank you so much for being with us. Mike, over to you.
Yeah, just a fabulous 2 days. I know we're running a couple of minutes over, so although I have so many, so much inspiration from all of you over the past 2 days, I will simply briefly say that connecting with all of you from all over the country and all over the world is what really keeps us going in our work. And we hope that making these connections with colleagues, hopefully colleagues who've become friends, will keep you feeling restored, engaged, and motivated to do the amazing work you do. So thank you for being a part of this, for all of the engagement. And as Bevan said, we are excited to see you in November, but to have lots of interaction with you before then.
Thank you so much. We'll see you at NARCAD 2025 this fall or at a community event between now and then. Take care and thanks for being with us.
Thanks so much, everybody. It was
Have a great
great
night.
seeing everybody.
Let us know if you need us. Thank you. Thank you, Deb.
Get some sleep, Deb.
Dave. Yes, get some sleep, Deb. Thank you, everyone. Dave and Rocco. Rocco, will I see you tomorrow? If you're still there? Oop. Maybe not still there. Zach, are you still there? I might kick you off. Okay.
That was great. Thanks for letting me be a part of this. This